and welcome to the Carilion Clinic Frequently Asked Questions for Building an Emergency Department Bridge to Treatment webinar. Today's presenters include Dr. John Burton, who is the chair of the Carilion Clinic Department of Emergency Medicine, as well as Dr. Sherry Hartman, who has many roles, but she is the Carilion Clinic Office-Based Opioid Treatment and OBOT Program Manager. Also joining them today are two additional subject matter expertise, Dr. David Hartman, who is the lead physician at the OBOT in the psychiatry department at Carilion, as well as Ashley Harrell, the Addiction and Recovery Treatment Services, also known as ARTS, Senior Advisor in the Behavioral Health Division here at Virginia Medicaid. My name is Christine Bethune, and I am a team member of the Support at Grant team in the Behavioral Health Division at the Department of Medical Assistance Services, which is also known as DMAS, which is the state agency that oversees the Virginia Medicaid benefit. DMAS is hosting this webinar in support with partners at Virginia Department of Health, as well as the Virginia Department of Behavioral Health and Developmental Services. DMAS has been collaborating with Dr. Sherry Hartman and Carilion Clinic to expand the utilization of ED bridge clinics. As a part of this work is through the Support at Grant, in which we contracted with Carilion to create an ED bridge clinic education curriculum to help support health systems implement their own program, which I'm sure Dr. Hartman will talk about today. Before handing this webinar over to our presenters, I just wanted to go over some information about today's webinar. Next slide, please. This webinar is being recorded and will be posted for later viewing. If you would like a copy of today's slides or the recording, please enter your email into the chat box, or you can email the support grant at dmas.virginia.gov, and that information will be in the chat box. We do have a closed captioning service available, so thank you so much to the captioner who's on the call. To access the service, please use the link in the chat box. The link will bring up an additional web page, and we suggest you resize your window so that you can see the presentation slides as well as the captioning service screen. If you have any questions about this service, please email the DMAS Civil Rights Coordinator. Their email is in that chat box as well. Next slide, please. This is an open format webinar, which means participants can unmute themselves and interact with the presenters to ask questions. We ask that you do keep an eye on that and make sure you stay muted if you're not talking. If you're unfamiliar with the WebEx platform, when your microphone icon is red, you are muted. If it's green, you are unmuted. If you have any technical problems during the webinar or would like to ask questions to the presenter as well, please enter those into the chat box. The DMAS staff will be monitoring to provide assistance. Next slide. Awesome. Through the Support at Grant, DMAS is offering free substance use disorder technical assistance and training webinars for anybody who works with Medicaid members. There are many different topics going to be offered during this webinar series, including a new topic, substance use disorder treatment and adolescence. Registration is now open, and in the chat box, we'll make sure to add a link to the schedule, a link to the Support at Grant webpage, which has previous slide decks from webinars that have been presented before, as well as the Support at Grant email in case you have any questions. Feel free to share this information as well. Okay, next slide, please. Thank you so much for everybody being here today, and I'm going to pass this webinar over to Dr. Sherry Hartman.
Christine, thank you so much, and thank you to Ashley, Harrell, and Jason Lowe, and all of you at DMAS for all the support that you are giving to this important work on treating opioid use disorders. I'm very proud of our Virginia DMAS department for really, I think, leading the country in putting into place best practices and supporting those of us who are trying to put into place best practices for treating opioid use disorder. And first, I want to just mention that we hope this feels more like a fireside chat than talking at you today. You're in for a treat with the availability of Dr. John Burton, who Christine introduced as our chair of the Emergency Medicine Department. John is the originator of the Carilion Clinic ED Bridge to Treatment model. And we've all been inspired by his leadership in this effort, and are very grateful to John for being here today. Full disclosure, I am related to Dr. David Hartman, who was introduced by Christine as the lead physician of our office-based opioid treatment program. He has one of the longest histories, certainly at Carilion, in treating persons with an opioid use disorder. So we actually husband and wife for 48 years now. So we're all glad to be available to answer questions today, and that is today's agenda, is to allow for your questions. I've also pre-populated a PowerPoint with some of the questions that have arisen to date when we started to roll out the Virginia Replication project together with DMAS and with the Department of Health. So though we have questions that have been submitted in advance and that we have answers to, our purpose is also to answer questions live today. So we do invite your participation, as Christine indicated. And also, we will introduce to you, just briefly, I'll make mention of our guidelines and the ED Bridge training toolkit. So this is not the Hartman and Burton show completely. We have a whole team that has put into place the Carilion ED Bridge to Treatment program. To date, I've heard we have 49 waivered physicians in the emergency department. And again, I think that's such a testament to Dr. Burton's leadership. This really has changed the culture of our emergency medicine department. We have in our OBOT, our office-based opioid treatment program, on the treatment shoreline of the bridge, 6 care coordinators led by our pioneer, Michelle Deal. We have 3 therapists dedicated to opioid use disorder therapy services, with our intake specialist, Leanna Stone, who's really taken the lead on receiving the ED referrals. We have a number of prescribers led by Dr. David Hartman, nursing support, administrative support. It's taken all of this to have a successful program. I have my email here on this slide. Feel free to email me if you have questions about this program that we don't get to answer today. I also want to make special mention of the peers that we have embedded in the emergency department. Thanks to DMAS's support, we're able to fully dedicate a peer to be present in the ED, and that peer is supervised by Kimberly Hunt, the supervisor of our Peer Recovery Center, and I've got that phone number there. Peers ended up to be highly playing a key role in successfully transitioning patients from the acute care setting of the emergency department to follow-up care. And this team does meet monthly, which we feel has been really helpful to having a successful ED Bridge to Treatment program. So the replication project is, our aim is to try to equip as many other hospitals as possible in Virginia to be able to stand up an ED Bridge to Treatment program. It's funded by VDH and DMAS through their federal resources. Christine mentioned the Support Act grant that funds the work that we're doing. Early implementer hospitals have been identified, and they are hospitals who came on board in December expressing interest in building an ED Bridge to Treatment program and benefiting from our consultation services. Our consultation and technical assistance is offered at no cost, thanks to the grants from DMAS. And there's actually no implementation requirement, because you reach out and say that you're an interested hospital does not commit you to putting that ED Bridge in place by any certain time. We do offer monthly meetings with these hospitals expressing an interest in being an early implementer hospital. If you are not already one of our 6 early implementers, feel free still to reach out. We'll offer whatever consultation and technical assistance that we can. We're going to put on in the public domain resources for all to use. All right. So I get at this point to let John Burton introduce yourself a little bit more fully and to bring up some of the questions that have been raised today. And on each of these topics, we're going to pause and let other folks ask questions. But John, the first one here has to do with getting waivered and completing a training about medication-assisted treatment. You stood this up when you had to do the 8 hours of waivered training. Do you want to address this topic?
The initial, yeah, I will back up and again introduce myself. John Burton, the chair for the Department of Emergency Medicine at Carilion Clinic here in Roanoke, Virginia. I've been the chair of emergency medicine at Carilion for the last 12 years. Our slides, as you can tell, are meant to be informative, not entertaining. So we're breaking some rules around how you create PowerPoint slides for a lecture, because we know that many of you may want the resources. So we put those resources and contact information on the slides so that we could instead try to emphasize the discussion. Okay, so initially, waiver training required 8 hours for physicians and 24 hours for physician assistants or nurse practitioners. And when we launched our program 3.5 years ago, Sherry, we had to do that training for our physicians. So the way we approached it on the emergency medicine side was we had a group of early adopters, if you will, that we identified out of our 60 emergency physicians. And that early adopter group was on the order of about 6 physicians that then pretty quickly expanded up to 12 of us. So we had about 6 people who were really interested. This is something they wanted to do. They were willing to be the canary in the coal mine, if you will. And so we all had to go through that 8-hour training program. The 8-hour training really was 4-hour training, repeated a second time. Was the way I looked at it, because you tended to do cases or some case discussion after the initial foundation of the training. I liked the training and felt it was very informative for me. Being an emergency physician, though, I'm always have a very short attention span, and also am not easy to educate because of my short attention span. And as a result, I would tell you that most of the information that was given in that training program, an emergency physician could probably pick up in a concentrated 15 or 20-minute discussion. Now, it was great to have all the extra background, but my bottom line is there's not a huge amount of new information that was in that that was peculiar to emergency physicians and not in our skill set. So once we had our early adopter group of 6 folks, we then inspired another 6, and then that got us up to 12. And we held on to that 12 for a period of time. Now, our practice setting is we have 6 emergency departments, and one of those 6 is a level 1 trauma center. Our efforts then were really focused on that level 1 trauma center initially, because that's where we had the OBOT connection to the Department of Psychiatry with Dr. Hartman here on the call, Dr. David Hartman, as well as Sherry Hartman. So we really focused in on that site. Again, on that site, we had 32 emergency physicians working. So our early adopter group ended up being close to a third of our group. The way we then covered the needs for the department initially was we had those physicians pretty much take call, so that if there was not a physician working in the ED who had undergone the waiver as we launched the bridge program, then those individual physicians could call one of the physicians on call. So I was one of them, and I told our physicians, you can call me 7 days a week, 24 hours a day, perfectly fine. I'll never get upset about that, because this is an important program that we have. We then were able to put a little bit of a financial incentive into our program around a scorecard program. And when we did that, that further incentivized a number of our other physicians to do that, or to do the training. And then finally, the final chunk of folks that have become trained ultimately got trained once the requirement for the training went away. So the current administration dropped the training requirement for the 8 hours for physicians. So now you don't have to undergo that training at all. To my understanding, Sherry, this will be a question to you or David. To my understanding, the physician assistants and nurse practitioners still have to do that training module, but has that been waived too?
Right, right. The exemption is, applicable to what we call ACPs, nurse practitioners, and physician assistants. As long as the caseload is, 30 or fewer, you don't have to do the 24-hour training as an ACP, nor the 8-hour training as a physician. And of course, those of you who work in the ED, you don't keep ongoing caseloads. So, when you submit your notice of intent, you just check off that box that you want the exemption from the training because you're not going to treat more than 30.
Yeah, so that's another myth that pops up is that emergency physicians will say, well, if I'm doing this here in the emergency department, I can only treat 30 patients. So how's that going to work out in the emergency department? That I'll quickly exceed my number of patients that I can care for. And as Sherry points out, an emergency physician who's doing a bridge type prescription or an induction type prescription is not included in the intent of that ongoing patient relationship. That's for the OBOT physician side to do that. And so the emergency physician, the ceiling for the number of patients you can care for is not relevant to an emergency physician's practice. So I guess I would summarize by saying on the training side, the training's all gone away that you have to have now. It's just a little bit of paperwork to get the waiver. It's processed pretty quickly, but even the training that was there previously was not terribly prohibitive at all. And then in a number of practice groups, physicians do have some small little incentive pools around quality initiatives in their hospital system that could be tapped into for opportunities. We have even seen another state, I believe it was Maryland, offered a financial incentive to physicians who would get their MAT training. So we've seen that in some other places in the country. But even without the financial incentive, of our 59 or our 49 physicians who are trained now, a good probably 30 or 35 of them did that without the financial incentive, simply because it was the right thing to do. We were launching our program, and we put a lot of emphasis on the need in our community and the opportunity of creating this bridge program, and that inspired them, if you will.
And Dave, I wondered if you wanted to speak to on the OBOT side. Did you see an impact after the emergency physicians got that training?
Well, I think that one of the keys was being able to work with the emergency room doctors to provide a referral for them so they could refer to us. And I think one of the important things in the office-based opiate treatment is to be flexible and responsive. So when a patient is started on Suboxone in the emergency room, we want to see them within a week or 2 weeks of that experience so that we can provide support to the emergency room doctors.
The other thing is you had spoken about patients talking about their experience in the ED.
Yeah, there's an incredible change in the patient's experience in the emergency room that previously patients were feeling viewed as drug seeking, pushed aside. Now, emergency room doctors, due to Dr. Burton's leadership, are really embracing, supporting, and engaging these patients so that they feel worthwhile, they feel treated and listened to. So it's been a really positive experience for our patients.
Yeah, and I would say as part of that, emergency physicians particularly, but also physicians in general, or anyone in healthcare, the reason why we're in healthcare is because we want to make a difference. We want to do something for people. And the frustration in the field of emergency medicine was there was nothing we could do for these individuals. And often, since there was nothing we could do for them. It became confrontational, it became frustrating because they had a need. We couldn't assist. There was nothing we could bring to the table. And then similarly, it often then went sideways too. You know, that people would have other complaints and things would translate into really taking the whole patient interaction sideways. So we were just really unhappy with it. And once we created a bridge program, it allowed us to do two things. One, we could get people into a program, and it's a great program that we had confidence in, and we were certain we could get them in. So that made it just suddenly, you know, it's like a dislocated shoulder. I can fix that. I can do something for that. So now I'm excited to see it. And then the other was now we could start the right patients on buprenorphine, and that made a difference in them. So we then started getting excited about seeing these patients because we knew we could help them long term, we could help them short term to get their cravings taken care of and get them off the street and away from the illicit drugs that they were using to fulfill that craving. And that just made a 180-degree turn in the way we looked at these patients. So that's what everybody really saw on the cultural side, on the back side with the patient experience.
I'll just, we're going to open it up for questions on this topic, but I'll just mention here that we have made available, and we've done it twice this year now, Dave primarily provides a training on medications for opioid use disorder, especially focusing on best practices for induction onto buprenorphine. And it's a 2-hour training that's been designed to satisfy our Virginia Board of Medicine requirement for any prescriber of any opioid to complete. It's especially designed to be that 2-hour length, so you can check off the box that you have done that training. And we actually did one on December 17th that was focused particularly on induction in the ED best practices. So we put onto this slide, as John said, a rather busy slide here of presenting a link to the training that will be available through March 23rd. And we've also got the CME survey link if you want our office to then make available CME credits for doing that training. Have we seen any questions in the chat, or does anyone want to unmute and ask any questions?
Or we can move to our next topic if nobody does.
Yeah, I've got a little bit more in depth on this topic actually on the PowerPoint. You know, one question that's come up, and this has been a source of confusion I've noticed even in my early interviews with hospitals, is about the 3-day rule versus needing to be waivered in order to write a prescription. And as you all may know, you don't need a waiver to initiate buprenorphine in the ED. You can administer it right in the ED for up to 3 consecutive days without a waiver. So the question is writing a prescription that does require the waiver really necessary? And John, would you like to address that?
Well, yes, sure. And our interpretation has been, if you're writing a prescription, it is necessary to be waivered. And if you are, and our interpretation has been that the 3-day rule is applicable if you're providing 3 days of medication therapy to that patient and actually dispensing it out of your hospital. The other one that often pops up along with this is methadone, because we'll have methadone patients who will come into the ED wanting methadone. And of course, as an emergency physician, you cannot prescribe methadone. However, you can give an emergency single dose of methadone. So it becomes a little confusing because of the different regulatory requirements between methadone and buprenorphine. But this does create a little bit of a window that if you were able to get patients into a bridge clinic 72 hours, you could give them a 3 consecutive day without the waiver. So that is an opportunity. I don't really like that as a strategy for emergency medicine unless it's absolutely necessary, because their patients are going to have a difficult time getting a ride. They're going to miss an appointment. So they need a little bit more time to get themselves squared away. And of course, the bridge has to handle the new patients coming over, and a 72-hour window is just a little too tight for them.
All right. And, you know, just pointing out that this is such a vulnerable time, this time of transition, you know, is when patients are most vulnerable, either for a repeat overdose or if they can't get access to continued care and you've got a break in care, you know, they're likely to use illicit substances, increasingly laced with fentanyl, which is walloping our patients and knocking them out. I know, David, you were telling me I've had patients, the impact of fentanyl that was unsuspecting. So continuity of care on our safe form of medication is really, really crucial. And the prescription helps achieve that. Thank you, John. And then the other question that has come up is about, is this a big hassle to submit your notice of intent in order to get waiver? It's actually very quick process. A few clicks gets you there. You have to go to the SAMHSA website, and I actually put the link here, become a buprenorphine waivered practitioner. They ask for your license number, your DEA number, you have to have those. And then you complete, you know, the rest of the form. It takes a minute for them to verify your credentials. And then you proceed with the form, indicating, if you're an ED physician, that you'd like the training exemption because you have no intention of a caseload that exceeds 30 patients. So just, it's as easy as that. It does take a little while, though, keep in mind, for this to get processed. So it won't take much of your time, but SAMHSA needs sometimes 6 to 8 weeks to process this. And I've gotten a number of emails and questions saying something went wrong, to use John's word, something went sideways on trying to get the XDEA number and to get waivered. If you don't get an error message, it probably went okay. And it's just that there is this lag in time to, you know, to get it processed. So at the bottom, are there any questions about that? Did anybody pick up on any questions on that topic? Should not be a big hassle. No cost involved. John, do you feel like incentives are recommended, that hospitals should put incentives in place to get physicians to become waivered?
Yeah, we covered this, you know, in our first slide there on that topic. But just to reiterate, I think that anytime you have an incentive available, great, let's put it into play. And for a hospital-based quality initiative or a hospital-based care initiative, I'm not sure you could get a better item to choose, because it's easily trackable. Did you get your XDEA? Did you get your waiver or not? Did you go through the process of doing that? And then you can track the prescription and prescribing that you have from it. So it's a great hospital initiative if you do have those incentives available. But if you don't, I think simply making a plea to the facts of the other pandemic that we have that has continued over the last decade, which is the deaths in the United States from the opioid crisis, is enough to incentivize healthcare providers.
Yeah, I would just add to that, I do think, and this is one thing I recommend to hospitals, is to get your senior level of administration visibly on board with the project. And, you know, we have here the opioid task force. We had Nancy Agee, who was at the time president of the American Hospital Association when we were standing up our ED bridge. And she did a wonderful video statement that was a kind of anti-stigma campaign for the American Hospital Association. And all of that matters. I think setting up a culture that endorses that addiction is a disease, that this is what we do in our field, is treat people with this disease, eliminating stigma so they will be willing to identify themselves and get into treatment. Even the treatment providers, I think in the past, and maybe sometimes now, feel stigmatized themselves. So we actually had a whole campaign around this. We created medallions that people put on their badges that said, I treat opioid use disorder. We put stickers up around, yeah, Dave, here is Dave's badge with that medallion. And we did this together with our peer recovery center, just endorsing that you can be really proud to be in this field. Here you go, Dave.
One of the concerns I've heard raised, and Dr. Burton, you might want to comment on this, is such an opportunity in the emergency room going to generate more business in an already busy emergency room?
Oh, yeah. I think that's on here about repeat visits, opening the floodgates question, John.
Yeah, so open the floodgates. And then we also have somebody who asked a question too, and I'll address that question that popped up in the chat screen. So opening the floodgates, this was a significant barrier to our emergency physician mindset. We had a number of well-respected emergency physicians who said, well, we don't like this because it's going to open up the floodgates of patients who are going to come into the ED. And, and the way we initially approached that, because we didn't really know whether it would or not, was we said, well, we think these patients are already coming here and we're not able to do anything for them. So at least we could now do something for those who come. And then secondly, if the floodgates open, we'll deal with that as it happens, and we'll try to figure out a way to, to address it. And so we'll track that and we'll follow it along, because we just really didn't have a good sense of what would happen in terms of the volumes. Well, the volume issue then is best out of our data set. What we saw was that after our first year in the Bridge program, when we looked at patients who had been enrolled in our Bridge program, and then we looked at them in our electronic health record for 1 year prior to their enrollment, and then we followed them for the year following their enrollment, right? So they got time 0 when we enroll them, and we're looking a year prior, and then we're looking a year after they've been enrolled. What we saw was that those individuals, number one, were already coming to see us frequently, 3 or 4 times a year was a typical patient in that subset for different things, not always substance use, often mental health visits or generally primary care issues because they had limited access as a general population to other healthcare resources, so they utilized the ED. But secondly, most importantly, was that when we compared their prior year before enrollment to their after year enrollment, their utilization of the ED went down 40%. So we immediately said, well, first of all, this floodgate concept is that, first of all, we've now identified these patients. We know who they are, and they were already utilizing us a lot, and their utilization of the ED has gone down. It's not gone up. Now, simultaneously, once it got out in the community to our referral base, physicians, mental health services, substance abuse services, and just the general public, we did have more people come in seeking this service. But we've never had more than something on the order of probably 3 or 4 patients on an 8-hour shift in a level 1 trauma center that sees 92,000 patients a year. So while the numbers did come up a little bit, They've never been overwhelming, and the time that we spend for enrollment for these patients is not a high amount of time in the ED. So bottom line is we debunked that myth with some data, and we also demonstrated that the floodgates are not so excessively wide, I guess, that we wouldn't be able to handle them. Now, another thing, speaking of the on the bridge piece, so one thing that someone asked in the chat here is when we refer people in the bridge to the treatment to the OBOT, do we do that through the electronic health record? And the challenges of navigating that through the electronic health record. Simple answer for us there would be no. We do send a notification often, not always, to Dr. Hartman to say, hey, we saw this patient in the ED. We gave them your referral information to follow up to the OBOT, so you may see this person, and hopefully you will. But we don't populate an appointment in his office or in any kind of appointment setting with the EHR. Two quick comments on that. First would be, we can't do that for primary care visits anyways in our EHR through our emergency department, which is a little embarrassing. I wish we could do that, but we cannot. And we also can't do it for our subspecialty services like orthopedics. Now, orthopedics is a great example. We can get people into ortho within 24 hours after they're seen in the ED. Primary care, it's a little bit longer and much more difficult because of the demands there. So what we did is we put in navigators on the back end that we can put in a referral order to a navigator, and then that navigator calls from the orthopedic clinic or has access to their schedules, and they'll call that patient. So we've never had a referral process in our EHR that worked. Secondly, when we built this program, building that into the EHR would have been a fair amount of time and complicated. And as I stated before, we didn't have any structure upon which to model it after that was successful in our program. So we ended up just basically saying, we're not going to bother with it in the EHR. Instead, what we do is we have a very detailed discharge listing of instructions that includes when the patient needs to call or show up to the clinic, where they need to do that, as well as all of our expectations of them as being in this program and what their expectations should be of us. So we've not tried to go after that EHR connection, and that's how we ended up making the connection. David, were there issues on your side, since we don't have an EHR connection, that in hindsight, should we have gone after that? What are your thoughts there?
I don't think so. I think it's worked fine. We bring them right into, well, we have peer recovery specialists that often play a key role in helping.
And the care coordinator set up the appointment.
Yeah, it's worked out pretty well in that fashion.
I would say, John, I remember your words to us were, keep it simple, make it as simple as possible on the ED side. So because we had just the one OBOT at the time, we could keep it simple. And what we did in the OBOT is you sent the chart to David Hartman, who, and Dave set up, you freed up a time slot. He just made sure that he could fit in patients. He just freed up time to do that. So did the whole team, really. And so we made that commitment to freeing up spots. And then we said we would do the triaging. If a patient was referred here and they were not, in fact, appropriate for outpatient level of care, we do the assessment and triage. And that way, the ED could just quickly, say, kind of a one size fits all. They all go to the OBOT, and then we determined the level of care that the patient needed.
So let's pivot to laboratory testing here on this slide as a great opportunity. And we had a question on urine drug testing, and then also a response around urine drug testing from the OBOT perspective. This was another element of keeping it simple. You know, when these patients come into the ED, how can we keep it simple? So we really try to strip it down to really what is necessary. And when you get down to it, there are no laboratory tests, urine tests, or any kind of screening lab or imaging study that's necessary for the vast majority of induction patients who are going to be started on buprenorphine in the ED in a bridge program. So if you're doing just a standard medical history like you would for every patient in your screening medical examination in the ED, then you're going to pick up people who have risk factors. Maybe they have hepatitis history or liver failure history or something. So sure enough, you're going to do that. But those are really by far and away the exception and not the rule. Now, then when we looked at it from the OBOT perspective, as well as from what would be ideal, then we said, okay, a urine pregnancy, liver function test as a baseline, a hepatitis panel, and a urine drug screen would be ideal from the OBOT perspective. Emergency physicians get their shackles up very quickly around urine drug testing in the ED because we'll say it doesn't make any difference in terms of how I'm going to treat the patient, and that is far and away true for the vast majority of patients. However, on the OBOT side, it is helpful for them to be able to see that information and to look at it from their perspective. So what we do is we will try to do these screening tests on our patients when they come in, both the labs and the urine. We do not hold them for the results, and we tell our clinicians up front, do not hold these patients waiting for results, because many of them, are anxious about holding people after they've sent one. Urine pregnancy is pretty easy because we can do that point of care testing there. But again, back to the urine drug test, it's not going to make any difference of what we do on the ED side for enrollment. So having a point of care rapid test there, from my opinion, would just not be of much use in the vast majority of patients. So we're fine with sending that to the lab with a couple of hour turnaround time and discharging the patient while it's pending. And we also won't follow up on it. We don't put it, we do have a follow-up nursing pool to follow up on laboratory tests that we have sent after a patient has left. And we don't drop these into that pool because the results will not ultimately have any implications for the patient care. And we trust on the OBOT side that the hepatitis or the LFT screens, they'll take a look at those on their side when we do obtain those. And if it is medically relevant while the patient's in the ED, then we will hold them until we get back the liver function tests, and less so for the hepatitis A, B, or C, unless the LFTs would be elevated. So again, bottom line is these are ideal practices for us. They're not required practices, and we emphasize to our physicians, don't hold the patient. We did have an experience recently in one of our EDs as we were setting up a bridge program with a community-based program. And that community-based OBOT program outside of Roanoke, we were really excited to get it up and going, as they were as well for their community. And one of the first things they said coming out of the gate was, oh no, in the emergency department, you need to do chemistries for electrolytes, a butane and creatinine, a glucose, an LFTs, because you need to be really doing a medical screening exam on all these people. To which we said, hold on now, this is not a mental health screening evaluation. And also we can pick and choose based on risk factors who we need to do this for and who we do not. And the vast majority of these people are otherwise reasonably young and healthy individuals who don't need a serum electrolyte panel drawn on them. So we reframed that question, and they just reflexively, because of their mental health background, said, oh, we want to use the ED for those screening things. Once we kind of reframed the position and had a good discussion with it, then they quickly said, oh, okay, fair enough. If you can just, order these things for us on the front end, and then we'll follow them up on the back end, and everybody was happy.
Yeah, that's worked well to be able to access the results of it, when it's been possible to get those drug screens done. Wouldn't you say they
Yeah.
rely on that?
Yeah, a lot of times our patients are not always easy to get drug screens,
Yeah.
particularly in COVID-19 pandemic era. And so having a drug screen at the emergency room that we can look at later can be very, very helpful. We are very excited in our office-based opiate treatment. We're starting to try to treat fairly uncomplicated hepatitis C. So hepatitis panels are helpful as well, again, to follow up from the emergency room.
Yeah, we've gotten 14 patients, I think, have resolved hepatitis C.
Wow,
So,
that's amazing. The
Yeah.
other things on this slide too to mention is we mental health issues often travel along with these patients, of course. So we do routinely screen them for mental health higher risk elements, including suicidality or concern of threat to others. We do that for all of our patients older than 12 years of age anyways. So that was nothing new for us. And it does deserve the comment too, that back to our emergency medicine perspective, we often would have people who would come in, it's not unusual at all, and say they're at their end of their rope with their addiction, they need help. And then when we would say, well, before the bridge program, gee, there's nothing we can do for you, and getting into programs takes months. It was not unusual for them to pivot and then say, well, I'm suicidal, I'm going to end my life because I can't do this anymore. And then they would be in our emergency department for anywhere from 12 to 24 or 48 hours holding for mental health beds, or in the best case scenario, 6 or 8 hours screening them in terms of their true need for mental health and working that out with our mental health professional colleagues. So that pivot was not uncommon for us. And then once we created the bridge program, suddenly that pivot did not happen anymore, because you have people coming in desperate who are at their end of their rope. We could do something for them, and then that gave that it reinstilled hope in them and hope in their future. So that was another thing on the mental health side that was something we would not have known going into it, and was something we really were grateful was a result of this. We did bring in peer counselors, and Sherry has mentioned that, and so we like to get them into the ED if they are in the ED, or to call them in if they're not. If we have a patient who comes in, if the patient doesn't want to wait around, if the peer counselor's not there, we don't require it. But we have shown in our data that involvement of a peer counselor does translate into an increased probability of that patient showing up in the outpatient clinic. So that peer counselor piece is just, it's a positive experience for the patient, and it enhances their outcomes for crossing the bridge and staying in the program ultimately. So we love getting that connection to happen. But again, if you've got an ED that doesn't have access to that for peer counselors, it's not a required element for it. We do try to get naloxone prescribed to these patients. We often don't do that nearly as much as we should. And we've tried to close the gap on that because it's clearly a vulnerable population. And we have many patients who come in whose lives are saved because someone used naloxone in their environment when they overdosed, and that naloxone was prescribed or dispensed by us. So we believe strongly in the naloxone piece. And then finally, social work and case management, where if we have an ED where social work case management is available, most of our EDs, they're not. But if they are, the main focus there is, how's this patient going to get their medication prescription filled? And are we going to do that in the hospital pharmacy, outpatient pharmacy? How are they going to pay for it? And if we have a social worker, that's where we really focus their efforts. But again, we try to make that a very lean and rapid consultation because most of these patients don't want to stick around, and I don't blame them, particularly during a pandemic.
There was a question in the chat, John, about the relationship with the pharmacy. You had met with our pharmacy
Yep.
early on in the process to make sure that there would be a supply of buprenorphine and that they would expect these prescriptions.
Yeah, yeah. So that's another great thing. Carilion Clinic being a clinic model, the departments will rally together and support one another. And ultimately, our goal is always to do the right thing by the patient. So we had many individuals in our pharmacy leadership. I think Charlie's on the phone here. And so he's another great advocate for us on the pharmacy side who basically said, we'll do everything we can at our hospital pharmacies to assure that if the patient can't fill the prescription as an outpatient, we'll do everything we can to help them fill that patient or pay that or fill that prescription before they leave in the ED. So we do try to do that, but we don't automate it for every single patient encounter.
All right.
I will just comment, our hepatitis C success has really been dependent on Charlie, who has played such a critical role. And I just wanted to, since
And
he's
that's
on
that's Charlie Taracitis, of course, who
he's
works out in
done
the River
a
Valley area.
magnificent job.
But thank you, Charlie.
So a question, one of the fears I think some of the physicians have is precipitating withdrawal. And I think it happens pretty rarely because we do look at the COWS score.
Yeah.
Look at the withdrawal level in the history, John. You don't see a lot of this, but do you want to address this question about how you would handle it?
Yeah, this is kind of like I used to give lectures on pneumonia, and occasionally a pulmonologist would show up, and I would be like, oh my gosh, somebody who really knows pneumonia is in the audience. And so that's the way I feel when I talk about buprenorphine, and David Hartman's in the room because his knowledge and expertise here is just textbook, literally, and mine is just a fraction of that. But here's my easy emergency physician way of approaching it. Because again, we like simple solutions. We have to have so many solutions on our fingertips. Is that we initially started out using 2 milligram or 4 milligram buprenorphine, and we would only use buprenorphine Suboxone combinations. We would not use Subutex in the ED. That was another question. So we would not use Subutex as buprenorphine alone. We would use Suboxone, buprenorphine plus naloxone, and we would start out, some of us, with a 2 milligram dose, 2/0.5, or a 4 milligram dose, 4/1, and often we would see a little bit of withdrawal, and we would be precipitating withdrawal response. Now, I never saw a really severe one, but I have colleagues, including one who's on the line here today, Dr. Wasdorp, who have seen those and have some firsthand experience with it. But I would see some mild withdrawal cases. And the treatment for that in the training for the buprenorphine waiver was simply to re-dose the patient. So if you give them 4/1 of Suboxone and they have some withdrawal symptoms, then you just give them another 4/1 and keep doing that until you treat them out of it. So what we quickly adapted was we quickly pivoted just to giving everyone 8 milligram, an 8/2 milligram tablet or film. So the vast majority of people, that's what we'll do, probably 92%, 95% of the time now. And we've not had problems with that. And a lot of patients too have been on Suboxone previously, and their maintenance dose was usually 8/2 milligrams twice a day. So they'll come in and we'll say, does that sound good to you? Now, we occasionally will have people who will want a higher dose. They'll say they were on 8/2 milligrams twice a day, and we'll generally refuse to do that. We'll say, no, our ceiling is the 8/2. And again, I'm not aware that we've had any issues with that. And with that strategy of just using that dose on virtually everybody, I've not seen a precipitated withdrawal. Then in terms of pill versus films, we like the films better if we can get them. However, we don't always have them, and we'll use the pill. So we will substitute those. And a key element here is when we write the prescription, you want to write on the prescription, may substitute films or tabs as available. So then the pharmacist doesn't have to call you back and ask you to make that substitution, because some pharmacies will only have one of the forms, pills versus films, and you don't want to have that be a barrier. So no issues there, pills versus films. David, you're the expert here. Does that all sound pretty reasonable to you, or have I gone astray?
We are seeing some work. Andrew Herring is an ER doctor out in California, and he's recommending that if you see precipitated withdrawal, to go up. I used to back off, but I think the thinking is now to go up to 16, even 20 milligrams of buprenorphine to try to overpower that precipitated withdrawal.
So you see a lot of today on day one, you'll actually see a lot more 16 milligrams. And some of the speculation is that the influence of longer term use of fentanyl makes it harder to have a successful override of withdrawal.
Right.
So, so a lot of places are going up to 16 on day one. I know we're going to be running out of time. We've already talked about, I think, this outpatient care question and the importance of the rapid handoff. John talked about the communications with the new program, just working out the details about what kind of labs you can expect or not expect. And, the benefit of peers if they're available but not required. We find that regular communications, we have monthly meetings, is really helpful. Somebody asked about whether or not it had to be an OBOT that you would refer the patient to, especially if they had Medicaid, because the OBOT is the preferred model. I don't know if Ashley actually wants to answer that. Ashley's made available a resource of OBOTs in your region. Ashley, what would you say about making referrals, let's say, to a straight MAT program that's not a preferred model?
Yeah, and that is absolutely okay. We encourage, I think the importance is getting access to the medication. We do, however, if there is a preferred OBOT within the community, Christine has put some resources in the chat. We encourage our preferred OBOT because they are meeting a higher threshold model. It's kind of like our gold card standard. And there's also the intense care coordination that is available through the OBOT model, along with the co-located behavioral health provider. So one thing we did include, there's a member fact sheet link, and within that fact sheet, we have a link to, or we have a contact for all of our managed care arts care coordinators. And one of their roles is helping navigate to community providers and seeing who's in their network. And then we also have a list. Our list for preferred OBOTs, we have now on that sheet, there was 187 sites, I believe. And we're getting ready to update it because we approved several additional locations this week. So I think we're close to 192 sites across the Commonwealth.
And another solution for setting up a program has been to partner with a CSB. John, you had good luck with partnering in Franklin County with the Piedmont CSB there. I'm always singing Monica Flora's praises because of how she's such a responsive partner. That's worked out well, Dr. Burton?
It has, and what we've said in each of our communities is we've got 6 EDs in 6 different communities, and we're ready to go with a bridge program if we can get an outpatient referral with or outpatient partner with anybody. We'll have a conversation with anybody to to get this bridge in, created in our communities. So the Franklin Piedmont CSB partnership there with Piedmont has been super for us. They've been a great partner. They approached it with a lot of questions. They were wanting to create a program and came to us and said, "Hey, tell us how to make this run. We hear you're doing this in Roanoke." And so we had a lot of back and forths with them and great conversations, and then launched the program. And I think we've had a lot of good success there.
Yeah,
Very
they
excited
have
about it.
the assessment they can do, and then they can triage to the level of care needed. A lot of it they can offer right within house. And they have peers who help them with the navigation and transition. So that has worked out really well. We've already talked about the floodgate issue. John has mentioned, yeah, go ahead.
Hey, Dr. Hartman. My name is Jessica Vermont, and I work with one of the health plans. And I know we may not be able to flesh this out here, but I am very interested in in looking at how we can partner and work with, because I'm sure a lot of our members are also, accessing this service. So I'm really interested to see who I could just really kind of start some conversation and dialogue about, to see how we can make sure that we are really building the bridge, right? Even from the health plan standpoint. So absolutely, if Dr. Hartman, if it's me, I can start reaching out to, I would definitely be open to do that.
Jessica, thank you for your question. And feel free to send me an email. I'm going to go ahead and repeat my email address, cwhartman1 @Carilion Clinic. I am all about offering advice as much as I know, and to link you up with others who might know more, to support bridging and using you as a resource, Jessica, potentially. We will be posting the guidelines for the ED bridge replication in a public domain. Ultimately, right now it's going to be shared with the early implementer hospitals and refined on the basis of the feedback from that cohort group. We're also developing an ED bridge training toolkit that I hope you all will find to be user-friendly, that'll have click-on tools that you can access for the various elements that comprise getting ready for an ED bridge and implementing it. And I did want to just mention, we won't spend any time on this, but House Bill 2300 actually created a wonderful summary of the best practices for opioid-related emergencies under the leadership of Dr. Barbara Allison Bryan, who led a work group on the topic. And they came up with these 11 best practices, and they align beautifully with the ED bridge model. So these two efforts were in parallel, but they actually in fact, line up really well with each other. So that is a great resource also for the policies that would support an ED bridge program. So please do feel free to be in touch. I've got my email. Oh, I put down the wrong email. Look at that. So it would be cwhartman1@carillionclinic.org, as per the earlier slide. cwhartman1@carillionclinic.org. And John's email is there as well. And Christine, any other final comments that you would like to make?
No, I think I really appreciate y'all being here and presenting, and everybody who attended. I thought it was really great and useful. And please enter into the chat box or email the support at Grant. Email if you want a copy of today's slides or the recording. Thank you.
The only comment I would throw in is to say thank you very much. Also on the healthcare plan thing, I think this is a great investment for healthcare plans because you're going to bring down ED utilization based on our data and experience. You're going to bring down mental health utilization based on our data and experience. You're going to have better outcomes. You've got just a lot of opportunity here for a healthcare plan that wants to do the right thing for its members to get better outcomes for the people in their plans. That's really exciting to me that, that we'd be look at it through that lens, and it makes total sense to me as a great opportunity. Anyway, thank you again. I really appreciate everyone, patience, as well as allowing me to participate on the call today.
Thank you all for your interest. Feel free to be in touch. Thank you, Dr. Burton. Thank you, Dr. David Hartman, and to our DMAS partners.